So we have a few minutes now for questions, discussion. Does anyone on the panel want to respond to anything that one of the other panelists said as people line up at the microphone? Okay.
Yeah, I'd just like to pick up on the theme that Mr. Farrington raised and other speakers raised regarding the incentive issue as well. So clearly, patient engagement models are key. And when we're looking at issues of incentive, there's also clearly physician referral bias, et cetera. What about other just a question for the panel in general, other models of care delivery? For example, multidisciplinary care. A patient is faced with a diagnosis and sees all specialists, and therefore may not be necessarily influenced by a gatekeeper or one bias in particular. So there's data on this. There's data that's looked at the adoption of active surveillance, which is the right thing to do in many patients with low-risk prostate cancer. Patients seen in a multidisciplinary clinic type environment have a doubling in the adoption of active surveillance compared to those who see single providers, even in succession of one another. The rates were something like 20 to 40%, a doubling in the adoption of active surveillance. So just a comment, or I mean, just really for the panel to comment on, this may not be a feasible model throughout the US, of course, but should that be an aim? Should that be a goal? Should that be a recommendation when we're dealing with issues of incentives, the adoption of new treatments, and perhaps trying to rid ourselves of physician referral bias?
So I'd be happy to comment on that, since I'm from an institution where virtually every patient is seen in a multidisciplinary same-day setting. And it's very expensive, it is time inefficient, but it's just something we believe in. Now, this keeps coming back to this incentive thing, because most patients, multidisciplinary is considered when they visit the various silos. And then the patient, like Tom said, is put in this awkward position sorting through data that is biased in its collection and presentation. So I agree, we got to take that out. But we can't create more systems to make up for things that were done wrong. And I'm a big believer that errors should be corrected. And the in-office exception is an error that can be corrected. And we can layer all these other things on that cost a tremendous amount more money to try and address this incentive, this perverse incentive that is throughout our healthcare system, or we can go fix it. It was mentioned earlier, you need legislation to fix it. Well, you don't really, because the words of the law, the Stark in-office exception, was a wonderful thing. So the Stark law said no self-referral. We would all agree with that. But then that meant that if you go to your family practitioner and you got a productive cough, they can't do a chest x-ray because they own the x-ray machine, that self-referral, or if you go in with burning urination, they can't do a urinalysis. So the in-office exception was meant to allow a laboratory test or a simple radiographic study to be performed in the on physician-owned equipment in the physician's office. So that's great. But then what happened is that was expanded to allow an MRI by the orthopedic surgeons in their own MRI facility. It was expanded to consider radiation oncology part of simple radiograph. This can just be fixed. So the problem is whoever first paid for self-referral a radiation treatment or a self-referral MRI. That shouldn't have happened. Now, who did that? Well, that was the insurers and CMS. So this is their problem. Why are we making it our problem? So this should just be done away with, and then that'll do a lot to take the patient out of this weird situation we're in where self-referral and cost is interfering with the proper assessment of our new technologies.
I mean, I'm obviously going to agree with everything you said on self-referral. But I want to go back to the first part of what you said. These are difficult clinics to put together, and I think that there's ample evidence that they improve care. But it is unfunded and difficult to coordinate. And many of us, I mean, I'm now practicing in an environment where a multidisciplinary clinic is unheard of. These things exist in large academic institutions. They don't exist out in that real world that I live in, and so I'm not exactly sure how we can learn from that and move forward. It's a great idea where it can happen, but it's hard to throw that out into the world at large.
Yeah, this is on the topic of clinical trials or observational data. I won't make any comment on should we, shouldn't we, but here is an observation on the observational side of things, registry if you want to call that. In the US, virtually every hospital that's treating cancer patients has a registry. Now, these registries historically, they came about by the American College of Surgeons, but they're codified. You have dedicated, trained registrars that are basically going into your hospital records and accruing information and patients from there. It has very good demographic data. It has very good tumor data. It follows, I believe, the AJCC. It has pretty good surgical data. All required fields for any cancer patient, regardless of how they were treated. What it doesn't have is very good treatment data, and it doesn't have very good outcomes data other than tracking when, if the patient lived or died. It seems to me the infrastructure is already here in the United States to do a fair amount of good observational data collection. What it needs is more backing or prodding or demanding by ASCO, ASTRO, to take those fields in the data set that right now is considered optional and make it mandatory. The infrastructure is already in place. Now, it's not rigorous like a clinical trial might be, and it might not have the richness of data, but that can come over time. Any of you that were involved with the NROR development of the prostate database knows that it took probably the better part of a year just to decide what data we wanted to collect. And that to me seems to be an issue that we run into a lot. By the way, my company actually has about 35% of those registries. We do registry data. And by the way, the information systems now that everyone's using are more than capable of electronically sending the required data to these registries. So the manpower involved ultimately would not be that much. But it does seem to me that the industry or the fields need to decide what data they think is important, with the understanding that you don't have to get it completely right the first time. It can grow over time. Otherwise, you just never get started. But then we can really start building a rich database that over the years will probably, I'm sure, provide some good information. It's the same information we're getting from the National Cancer Institute now, right? Excuse me, the American Cancer Society. That's where that data comes from. It comes from these databases.
So let me take the moderator's prerogative of responding to that to some extent, and Jim's provocative comment about doing away with randomized trials. So the challenge of registry data, no matter how granular it is that there are biases that occur, and sometimes strong biases that occur before that data ever is generated. Probably the single best example we have is high-dose therapy for high risk and metastatic breast cancer. No matter how the data was looked at, the non-randomized data was looked at, high-dose therapy looked like it had a major survival advantage. The randomized trials, when they were performed, demonstrated that that was a selection bias outcome, and that the high-dose therapy was not more advantageous and actually may be deleterious. and certainly more difficult for women to experience. And the story is that medical oncologists were just very skilled at selecting people who could tolerate high-dose therapy, and those people who could tolerate high-dose therapy are simply healthier and more fit, and so they do better. Had nothing to do with the actual therapy that was delivered. So there are important clues and information we can get from non-randomized, high-quality registry data, but we have to be very, very cautious that we don't get fundamentally misled and follow a pathway that we're following downstream that has nothing to do with the effectiveness of treatment, but everything to do with the biases of the physicians. Do you disagree, Jim?
No, I don't disagree, and I want to clarify. I was told to be provocative. I think we are overly obsessed with randomized clinical trials. I have a talk that I give on medical treatment of advanced prostate cancer, and I point out that every randomized clinical trial done of the new agents extends survival between 2.4 and 5 months. To me, as a surgeon, I go, so what? So there are places, though, where they need to be done. We can't get obsessed with saying that we can't adopt any new technology in this space without a randomized clinical trial. That's my point. I also, I think we should look at more innovative statistical designs, and I was very interested in Jim's comments about alternatives to randomized clinical trials, and yet you didn't get all the way to what industry uses. And I think we need to really take a look at that. Now, registries are good, but like everything else, there's limitations. Clinical trials, randomized clinical trials, all have limitations.
So I agree that there needs to be balance around this question of evidence. And I would suggest to the panel and the audience taking a look at Michael Rowland's Harvey Society talk. I believe it's published in Lancet in maybe 2008 or 2010, where he describes the balance and the role of randomized clinical trials to answer certain questions and the importance of observational databases and other methodologies. You know, and they always cite the example of patent ductus arteriosus. You don't need to do a trial, you just need to do one case to understand that you fixed the problem. And there are many examples that he'll cite in that article. We talked a lot about randomized clinical trials. We also talked about the difficulties of doing those observational databases, but somewhere in there is the ability to answer a lot of questions, because the reality is, in this world of increasingly personal and personalized medicine, there will be an infinite number of randomized trials to be performed, and randomized trials have their own problems with generalizability, being accurate, and so forth. So we need to strike a balance across that continuum and accept all types of evidence to move the field forward, particularly as it relates to technology.
Can I just add to that? Because, you know, it's specifically, I think, important for this conference where we're talking about advanced technologies that you know, I'm going to pick an IMRT or proton therapy because I come to it from the radiation side, but you can envision a demand for a randomized trial on each and every organ system, on each and every disease, on each and every stage. I mean, the magnitude of the problem is obvious. And so I think, as Dr. Steinberg suggested, there are times when a randomized trial can answer an important question. And there are times when the randomized trial just isn't going to be the way to go, but we need to have other modalities that we can look at and other ways that we can answer questions in ways that the world at large, the larger world, will look at and believe.
I'd like to add two brief things to that comment specifically. I agree, and But it shouldn't be that these opportunities are quixotic. They should actually be organized, and they should be in a framework. I really like Sean's framework. When some of these technologies come out and they're very, very expensive, we should pause before we just think maybe we do or maybe we don't need a trial or need a systematic study. The other point I want to make is that we should recognize that observational studies have a lot of power, they have a lot of limitations. They're really good for generating signals, and they should be part of a learning healthcare system that gives us feedback that we can then use to generate the right next kind of studies. I think we just don't do it in a very organized way. We do it rather quixotically, and I think that's really something that this conference should help address.
I thought Dr. Vikram was going to, but it looks like you disappeared. I was going to, anyway, okay. So, I mean, the issue around the randomized trial, I just want to say a little bit more about it because I seriously struggle with it. And I'm as, kind of sensitive to, I think Jim was sort of motivating, your comments, particularly in surgery, where it's just, the feasibility of being able to successfully enroll and conduct, these things in any kind of efficient, reasonable way, it seems so onerous at the attractiveness of these statistical process control methods or, other alternatives, extremely appealing, with the small problem, which is occasionally they get the answer horribly wrong, in which case, you've harmed a lot of people before you figure that out. And, one just, illustration, and this, amounts to an anecdote, but in the case of lung volume reduction surgery, which was, one of the early Medicare's first attempt to do the coverage with evidence before it was called that, this had become this, wildly popular procedure that was being billed to Medicare as a bulectomy, but was really, quite a different procedure. It was enthusiastically adopted for all the reasons we heard about here. It was, the clinicians loved it. It seemed to, sort of anecdotally, at least in case series, be dramatically effective for severe COPD. When somebody looked at the claims data, it looked like actually the mortality rates were a lot higher than was being reported by any single institution. So NHLBI, cooperated with FDA and Medicare and, launched a trial which over the course of 7 years and $100 million enrolled, 1,400 patients, and Medicare paid for the patient care. And, the study found that there was a modest benefit in a subset of patients, and, in another subset of patients it was killing people. And what happened was, and I was at Medicare at the time, we essentially said, okay, it's, based on this modest benefit in a subpopulation, we'll cover it if, as long as you kind of tell people what the benefits and risks are. And the procedure was just abandoned, which probably would have happened eventually without the trial. Probably they would have eventually figured out that they were killing a lot of people. But it looked like the observational data wasn't probably going to do it. I don't know if, looking back, whether a statistical process or some alternative way would have gotten the answer faster. But that being said, it doesn't seem to me to be a great model to repeat, because who's going to be able, who in their right mind would wait, 10 years and 1,400 procedures, especially if it was a commercially backed procedure of any kind. No one's going to make the investment over that period of time and that amount of money, $100 million, to answer that question. So it kind of leads me back to, something that looks, what I was trying to sort of lay out is that there needs to be some kind of stepwise but structured, well-defined process of sort of sequentially more rigorous studies where you hopefully, again, not in a ad hoc way, get smarter over time according to some framework like the ideal framework, progressively more rigorous and more expensive and more, sort of high, higher validity studies, that at some point the payers will agree that there's enough evidence to pay for it, but before the randomized trials are done. And if you still think there's enough uncertainty that a randomized trial ought to be done, that's done after the fact. But anyway, the point is, what I think we have now is a sort of it depends on people like, Jason and Justin and Anthony Zeitman to, get up the nerve and energy to do, to do a study. It's not organized and systematic enough.
Yeah, it's a variation on the theme of what we heard yesterday in terms of the difficulties of de-adoption. That de-adopting is much, much more difficult than adoption. Did you have a question over there?
Yeah, this is for the panel. Coming from a LINAC manufacturer point of view or side of things, what strikes me about what we've talking about the last 2 days is, are we talking about an issue that's unique to the United States, or is this healthcare in general? And the reason I say that is this. For all the discussion about new technologies and new features on old technologies, and I'm talking about radiation machines right now, not proton machines. The reality is that while the U.S. definitely is the early and very rapid adapter of new technology, in my 30 years in doing this, I've yet to see a technology on a LINAC that was adapted and used here in the U.S. prolifically that has not been adapted over in any of the other Western mature countries in the world. Now, you can talk about utilization, but the machines that we build and deliver here in the U.S. are exactly the same as we build and deliver in every other country of the world other than the emerging markets. And even they rapidly uptake this new technology. So how do we, what is the problem we're trying to solve here? Or what is the issue we're trying to address? You know, it seems like implicitly we're saying, geez, we spend too much in the United States. Look at England and look at the European model. They spend less. But at least as far as in radiation therapy goes, they're buying the same equipment and they're treating the same patients.
Actually, over a long period of time, it's been shown that they don't treat the same patients. They treat fewer patients. They do better rationing. They do better decision-making.
That's a good point.
And they also actually, in a lot of technologies, they don't treat patients. The best examples are in end-stage disease of different types. End-stage renal disease is the best. They actually don't. But I think your comment is actually reflects something I said, and I'm going to repeat it. The international market is not so dissimilar from us. They're a little slower. They're more organized in adoption. And we don't leverage the fact that we may want to adopt something faster and use international comparisons, use gradual administration of new technologies more systematically to give us feedback whether these technologies work. There are real opportunities for this, opportunities for companies, opportunities for joint regulatory agency action, opportunities for researchers to actually leverage this, and opportunities for the NIH in particular. And we really should use that. There are a number of designs. Jim mentioned the cluster randomized trial. You could modify that in international settings, and you could really get a lot of bang for the buck, and we could answer fundamental questions more rapidly. They don't all have to be purely randomized trials. We're better off when they have some element of randomization by far, as opposed to completely observational. But there are a lot of innovative methods that we can use. And then I think we would actually help solve problems.
Hey, I have a question for you. You raised a real good point. I meant to bring that up. You're right. In the U.S., I think the number is 55% or so of cancer patients probably get radiation at some point. Rest of the world, even the more mature world, I think the number is more like 25 to 35%. The question is, what's the right number?
I can just share with you that some of the radiation oncologists in developed countries that are down in the 20 to 25% truly believe that their number is not right. They have a lot of underutilization in radiation. They have some problems that we don't, but they have real problems.
And with that, I'd like to thank the panel very much. Thank you, and turn it back to Dr. Shi.